So far, no evidence-based clinical data exists showing superiority of biodegradable polymer-based versus durable polymer-based drug-eluting stents. At least to me, none of these data are really convincing. Today, even the opposite, a protective effect is discussed by some polymers. So maybe polymer is even a good thing to have on the long run. And modern drug-eluting stents with durable polymers are the gold standard, at least the ones I've shown you, and hard to beat. Yes, maybe we are already at the limit, which cannot be improved anymore. And last but not least, and this is my personal opinion, avoiding biodegradable polymer-based drug-eluting stents does not put the patient at risk. They were all the same, and saves healthcare costs. So I think it's a very good situation that you treat the patient optimally and still save money. Thank you.
Thank you very much, Sigmund. As usual, very well balanced and convincing position. Perhaps the members of the panel, or of course the audience, if you have questions, please stand up to one of the microphones and you have priority. But would members of the panel like to react to Sigmund's views?
Yeah. Could I have the
Ashok.
Yes, I do want to respond and perhaps put some thoughts in and say that, these are all comers and we have that, but over here maybe, do you think a year is not enough to tell us the differences in this group of patients? And that's the first aspect.
Yes, I totally agree. We probably need another 4 or 5 years, and the 23 trial will follow up for 5 years. But drug-eluting stents with bioresorbable polymer, they are around for many, many years. So we still should have the data, at least from the first generation of these stents. Again, this is not convincing. So I think if it takes 10 years after a new concept has been introduced to show, if at all, any advantage, that's too long. And until we don't have the data, why should I use it and pay more money for it?
So the second aspect comes in that it's an attractive proposition to have a biodegradable polymer, but you're absolutely right. There's now data coming in very strongly for the polymer and the fact that it actually is fairly protective in terms of thrombosis, and that's why we see such good results with some of the stable polymer stents as years go by. My issue comes in, perhaps more studies should actually be done in extreme high-risk patients, the ones who are either high risk for thrombosis or for the ones who were earlier dual antiplatelet therapy can be withdrawn, because you have to have that substrate to actually start showing benefits, if any, can be shown. And these substrates have to have inherently either a high thrombosis rates or an ability to withdraw antiplatelet therapy at a month. That's the sort of thing that we should try and do to separate the benefits out. Otherwise, I don't think we would be able to show benefits on such when the event rates are so low.
Yes, I completely agree, but we had 5 or 6 years time already to do so. So why didn't we do it?
And I'll tell you why.
So can we sorry, Clement van Beerden answer? He's after all responsible for one of these 2 trials.
Thank you for this interpretation. I think in great lines I completely agree with what you say. The point about the cost is a moving target and will differ from one country to the others. There are certainly countries where the costs are not different or where this issue is not really important. I think what we have shown with the BioResort trial is a short-term safety at 1 year of this novel devices. As we started with the 20 trial in parallel with the Resolute All-Comers trial, showing first at 1 year and then later on up to 5 years that the Resolute stent is safe and could be considered to be a new gold standard besides the everolimus-eluting fluoropolymer stents. I think we have seen results of 2 novel, very thin strut stents that have also the potential on long term to show something similar, to become new gold standards. And the long-term results are definitely of interest. What we can tell the physicians and some patients who feel that they would prefer to have a stent without a durable polymer stents, and as you know, also the newer generation durable polymer stents have occasionally accelerated and early new atherosclerosis, while bare metal stents are known to develop that after several years, and thus much later. And we can tell these physicians or patients that it's safe at 1 year follow-up to use these novel devices with the potential to later on have low event rates or not. But this will be evaluated later on during the follow-up of the trial.
Yes, well, I agree, but on the other hand, I'm a little bit skeptical with all these potentials. And I like to use in patients what's really established, that we have seen the results of the fully bioresorbable stent or scaffold yesterday or day before yesterday. So the theory was maybe in a couple of years it's going to be better and the vasomotion will improve, and these things didn't happen. So let's stick for our patients what's established. Everything else can be done in randomized trials. I'm a fan of randomized trials, but the patient has to be aware this is a trial or this is everyday practice.
Yeah, we started with the 20 trial also with the potential and with the idea, as you started with the Resolute all-comers, with the idea that the Resolute stent might be as well a gold standard. And I think we should be fair for these novel devices and really underline the fact that these results are very, very good for the Synergy and for the Osiris stent.
You should be commended for planning a 5-year follow-up, because that's important. I think we as a group are very impatient physicians, and 5 years seems like close to eternity, and Sigmund's just reminded us that 10 years just doesn't exist, because we know that in 10 years we hope that we'll be using an entirely different set of tools. So we should remember leaders, not leaders-free leaders, took 5 years to show a difference against Cypher, and Protect took, I think, 4 years to show a difference. So I agree with you, we have to wait these 5 years, but I think Sigmund has a point. We're spending money today on potential benefit tomorrow, and that may not be the right sort of arithmetic.
The only counterpoint I was going to add to that, I mean, that is clear for the clinical endpoints, but the premise of the polymer going away is less about late neoatherosclerosis and more about early healing. And so at this scale of trial, over 5,000 patients, I mean, the issue around whether we saw some early stent thrombosis differential or protection from these platforms, we didn't see it. And I think that is, gives us some suspicion that, maybe that benefit, if it's present, is actually pretty small.
Yeah, I agree, but prove it.
Well, I think you've done a good job of disproving
it. Other comments, Bernard?
Yes, I think we have reached a kind of plateau in terms of safety efficacy profile. I think it's very difficult to prove any benefit with a new technology, and we should keep that in mind. As Ashok said, we probably need to go to a specific subgroup of patients to demonstrate a clear benefit of the technology versus another one. I think, in general, I agree with what you said, Sigmund, but I think the last point, disagree with the last point when you say that we have to use a durable polymer for the safety of the patient. There is no proof of that. There is a proof that so far all these bioresorbable polymers are equivalent to durable polymer. So this is the only thing we can say. One last point, I think it's partly interesting to see that in the 23 trial, 2 bioresorbable polymer coated DES with totally different kinetic of absorption have exactly similar results.
So maybe the rate of resolve, the polymer resolves is not so important. I mean, so totally different rates of dissolving and the same results.
Can I have another point?
Please, go ahead.
And yet you see a proliferation, truly a proliferation of cobalt, chromium, bioresorbable, sterile coating, sirolimus eluting stents practically coming from every country across the world. And you know why that is? So that when I say this, I say it with a point that you've done a great job, this study's done a great job of proving that's no superior, because those stents are local, those stents are for the local population. They are actually going on the emotions and intuitively attractiveness of this fact about the polymer going away and turning into a bare metal stent, and they're capitalizing on the local market, hopefully, to get a share of the market. And let's not forget the economics of it. While you may say expensive, those are actually cheaper when available in India and China and so on and so forth. And actually, all the Chinese stents, which is 80% used, are cobalt chromium bioresorbable polymer because it's intuitively so attractive.
But
But I'm just wondering about a side effect of some of these beautifully conducted trials which target non-inferiority. I mean, the side effect gradually is that we have a feeling that we're talking about a commodity because they're non-inferior, so it means they're more or less all the same, and then it becomes an emotional issue and a financial issue.
Correct.
And is that in the interest of the field? Anyway, it's a fact. It's a fact of life. It's the way things are.
It's a fact of life.
I mean, to add to that, I mean, we are definitely going to see the emergence of a greater focus for reimbursement on outcomes and less about procedures. So, you know, we're looking to embrace that, I think.
Talking about potential and ideas, we will later on talk about the bioresorbable scaffolds, and when we talk about the investments made there, without yet having a proof that these devices are really better for our patients, the investment in this trial is really minor.
And very reasonable, absolutely. Other comments before we move on? Some of the panel members have been very cautiously quiet. Could we induce them to give an opinion?
You know, I think that this is a bittersweet situation. I think, you know, if we're going to drive intervention, you know, industry and stakeholders who are interested in this have to have something to go after. And the good news is this is great news for patients, and I agree with the comments that were made in terms of being able to access multiple different very good stents across the country, across multiple nations is very important. It's good for patients. The only consequence of it is, you know, again, investment is going to be cautious because there is a ceiling effect, and we're seeing it. And as a clinical trialist, we're going to have to be very sort of creative about how we try to look at this. And the further we deviate from the gold standard of our standard clinical outcomes, the less externally reliable and applicable those trials will be. So I think that the future's bright but dim because we've got great outcomes, but I have a feeling that at some point, you know, it's just going to be, like you said, a commoditized issue, and then industry investment and interest is going to wane. They're going to spend their money somewhere else, and that's the downside of all this.
Thank you. So we'll have a closing remark by Sigmund.
Well, you always, after such presentations, you ask who is the winner, and I'm really convinced the winner is the patient, because the patient can be said no matter which of these new or drug-eluting stents we use, we are at the ceiling, the results are the same, so I think it's very good for the patient.
Thank you very much.